Hello everybody, this is the lecture of antibiotic and septicemia, presented by Dr. Yasmin Abdelatif, lecturer of tropical medicine. Welcome to our tropical medicine department. This is a slide showing a 10-year challenge for antibiotic resistance. In the first image, antibiotics were sensitive to most bacteria, while 2019 antibiotic resistance has been currently an issue. Factors to consider when choosing antibiotics: patient recent antibiotic therapy, hospital flora, presence of underlying disease, and available culture data, current and past. When you think to choose an antibiotic, you must think about location of the infection, where did the patient become ill, and travel history, exposure history. Where did the infection anatomically originate, and when and where in the body has or will the infection spread to. Here is some example for the antibiotics we commonly use. Beta-lactams group is a wide family including penicillins, cephalosporins, and carbapenems. Cautions: beta-lactams allergy occurs in 10% and 5 to 10% cross-sensitivity in penicillin, cephalosporins, and carbapenems. For the side effects, most of the antibiotics causes GIT side effect, including diarrhea, nausea, and others causing rash. Quinolones, including ciprofloxacin, fluoroquinolones. Cautions with quinolones in old age because it causes QT prolongation, tender eruption, CNS toxicity. So don't use in the patient with epilepsy, existing CNS lesions, and inflammation. And the most common side effect is Clostridium difficile. Macrolides, including erythromycin, clarithromycin, and azithromycin. It's a broad spectrum against gram-positive, including strep and staph aureus, especially MRSA, good for atypical organisms like Mycobacteria, Chlamydia, and Legionella, covers also Neisseria, gonorrhea, and Legionella. Caution: can interact with statins to cause myopathy and can cause QT prolongation. And also the side effect mostly is GIT upset. Lincosamide, for example, clindamycin, uses reasonable gram-positive anaerobic coverage against strep and many staph, including MRSA. Special rules in treating of strep in necrotizing fasciitis: anaerobic coverage better than penicillin, but not better than metronidazole. Caution: can interact with neuromuscular blocking agent and cyclosporin. Also the side effect, including diarrhea and also commonly causes of Clostridium difficile. Avoid clindamycin if other good options exist. Metronidazole, which is commonly used here in our country in the name of Flagyl, uses no aerobic activity, but it is a good anaerobic coverage, does not stand alone for mixed infection, good coverage of anaerobe, and can be used for Clostridium difficile, parasites, and bacterial vaginosis. The dose of metronidazole differs according to the organism is treated. For example, amoebic hepatitis and amoebiasis can be given, for example, for 750 milligram twice per day or 3 times per day, while in gastroenteritis we give it 500 milligram 3 times per day. Caution: may require reduced dose in liver disease and can increase the effect of warfarin. Side effect: nausea, GIT upset, seizures, peripheral neuropathy with prolonged therapy. 9 factors to consider when selecting an antibiotic: the spectrum of the coverage, pattern of the resistance, evidence or track record for a specified infection, achievable sampling, serum, tissue, or body fluid, for example CSF or urine, allergy of the antibiotic, toxicity, formulation IV or oral, and adherence and convenience. For example, we have to do it 2 times per day, 3 times per day, and not 6 times per day. And also the cost of the antibiotic. To increase directed therapy for inpatients, define the infection anatomically, microbiologically, and pathophysiologically. Obtain culture before starting antibiotic, using imaging and rapid diagnostic and specific procedures in early course of infection. Have the courage to make a decision. If empirical therapy is started, reassess after 48 to 72 hours and move to the directed therapy to eradicate infection. Treat only bacterial infection and not colonization. Many patients became colonized with potentially pathogenic bacteria, but they are not infected, such as asymptomatic bacteriuria or Foley catheter colonization, tracheostomy colonization in chronic respiratory failure, chronic wounds, lower extremities stasis ulcer, venous ulcer, and chronic bronchitis. Treatment of asymptomatic bacteriuria in elderly, it is a multi-spectrum randomized clinical trial, have shown no benefit. Also, don't treat viral infections with antibiotics, like acute bronchitis, common cold, sinusitis with symptoms less than 7 days, sinusitis not localized to the maxillary sinus, and pharyngitis not due to group A Streptococcus staphylococcus. Limit the duration of the antibiotic therapy to the appropriate length. Ventilator-associated pneumonia needs only 8 days. Most common community-acquired pneumonia needs also 5 days. Cystitis 3 days, pyelonephritis 7 days if fluoroquinolones used, intra-abdominal with source control 4 to 7 days, and cellulitis 5 to 7 days. As regards sepsis, for diagnosis and management of sepsis and septic shock, we have to know some terminology. Sepsis and systemic SIRS, systemic inflammatory response syndrome, temperature for more than 38 degrees, our heart rate more than 90, respiratory rate more than 20 per minute, and white blood cells more than 12. 2 out of 4 criteria acute change from baseline. Sepsis, it is the systematic inflammatory response to the infection. Severe sepsis, organ dysfunction, secondary to sepsis, starting with hypoperfusion, hypotension, acute lung injury, encephalopathy, acute kidney injury, and coagulopathy. Septic shock, hypotension secondary to sepsis that is resistant to adequate fluid administration and associated with hypoperfusion. Infection can be caused by bacteremia. This is the most common cause, but there are other causes such as fungemia, parasitemia, viremia, and others like stroma, burns, and pancreatitis. The management: initial resuscitation, fluids and pressors, microbial diagnosis, antimicrobial therapy, source control, and infection prevention. You must take home message. Make sure you try to collect cultures before starting antibiotic. Many antibiotics require renal dosing, such as vancomycin. If you aren't sure of the dose, call the pharmacist. Again, this slide for antibiotic resistance. Be wise when you use antibiotic. Thank you.